Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to another Solid Anatomy lecture. Now, if you've watched the Solid Anatomy lecture on the pleura and the lung, you may find yourself wondering about the process of respiration. If you take a physiology course, then you're going to learn lots of information about respiration in terms of gas exchange and diffusion rates and oxygen hemoglobin saturation curves, and that's going to give you an opportunity to put your math skills into play. But in this Solid Anatomy lecture on respiration, we'll discuss respiration from a largely mechanical perspective, mostly with regard to the muscles involved in the process. We'll also switch gears later in the lecture after discussing respiration and move our discussion towards the heart. We'll talk about the pericardium and then the external surface of the heart as well. Now, I'll be back later for some clinical correlations and the end of session quiz, but for now I'm going to turn it over to our primary lecturer, Dr. John Phelan.
How does one persuade air to enter the lungs, or more specifically, the alveoli, which is where gas exchange occurs? Perhaps you recall from your physics class in high school that one of the principles derived from Bernoulli's theorem is that air moves from an area of high pressure to an area of low pressure. The alveoli are connected to the atmosphere by the bronchial tree, the trachea, and the pharynx. So, the trick is to lower the air pressure in the alveoli with respect to the air pressure of the atmosphere. According to Boyle's law, increasing the volume of a space causes the air pressure within that space to drop. So what's a good way to increase the volume of the alveoli? The alveoli and the lungs are elastic. And recall from the Solid Anatomy lecture on the pleura and the lungs that the lungs are adhered to the thoracic wall and the diaphragm by surface tension exerted by the pleural fluid. This reduces the air pressure within the alveoli, resulting in air moving from the atmosphere through the pharynx, the trachea, the bronchial tree, and into the alveoli. The bottom line of all of this is that we can persuade air to move into the alveoli by increasing the volume of the thoracic cavity. There are three dimensions in which the cavity may be enlarged to achieve inspiration. The superior to inferior diameter of the thoracic cavity may be increased by the action of the diaphragm muscle, which fills the inferior thoracic aperture. At rest, the diaphragm muscle appears as a pair of domes whose convex sides are pointing into the thorax. When the diaphragm contracts, it flattens, which increases the distance between the peak of the cupola and the center of the central tendon of the diaphragm. This increase in volume is sufficient for ventilation at rest. Recall from the rhyme, 3, 4, 5 keep the diaphragm alive, that the diaphragm muscle is innervated by the ventral rami of spinal nerves C3, C4, and C5. The lateral diameter of the thoracic cavity may be increased by elevating the ribs, which causes the distance between the left and right ribs to increase. The analogy often given for consideration of this action is lifting the handles of a pair of buckets. In the neck, 3 scalene muscles take their origin from the transverse processes of cervical vertebrae 2 through 7. The anterior and middle scalenes insert on the middle of the first rib, while the posterior scalene inserts on the middle of the second rib. When these muscles contract, they are bringing the first and second ribs closer to the transverse processes of the cervical vertebrae, so they are elevating them. And all of the ribs are connected to each other via the intercostal muscles. So when the first 2 ribs are elevated, all of the ribs are elevated. The scalene muscles are innervated by direct branches from the ventral rami of spinal nerves C4 through C6. The anterior to posterior dimension of the thorax may be increased by elevating the sternum, which increases the distance between the sternum and the vertebral bodies. The analogy given for consideration of this action is raising the handle of a water pump. A muscle that is particularly effective at elevating the sternum is the sternocleidomastoid, which originates at the manubrium of the sternum and the clavicle, and that's the cleido portion of sternocleidomastoid. Cleido is Latin for clavicle. And the muscle inserts on the mastoid process of the skull. When the muscle contracts, it elevates the sternum. That is, it brings it closer to the skull. The sternocleidomastoid is innervated by the spinal accessory nerve, or cranial nerve number 11. When the diaphragm muscle relaxes, its central tendons extend superiorly into the thoracic cavity to form a pair of domes, which effectively decreases the superior to inferior diameter of the thorax. This, along with the natural elastic recoil of the lungs, is sufficient for normal expiration. To forcefully expire, the ribs and the sternum must be depressed to decrease the lateral and anterior to posterior diameters of the thoracic cavity. The muscles of the abdominal wall are effective here, especially the rectus abdominis muscle, which attaches to the sternum and the costal margin superiorly, and the pelvis inferiorly. Contracting these muscles also compresses the abdominal contents, forcing them superiorly against the diaphragm to further decrease the superior to inferior diameter of the thorax. The muscles of the anterior abdominal wall are innervated by the thoraco-abdominal nerves, which are continuations of the 7th through 11th intercostal nerves beyond the costal margin. While some textbooks assert that the intercostal muscles act on the ribs to assist with respiration, their most important contribution to this process is probably isometric. That is, they contract to keep the intercostal spaces rigid during inspiration and expiration. If they did not contract, the intercostal spaces would bulge inward, an action known as incursion, during inspiration, reducing the volume of the thoracic cavity and thus reducing the amount of air inhaled. Likewise, during expiration, the spaces would bulge outward or excurd, making expiration less effective. While the serratus posterior, superior, and inferior muscles are traditionally said to be accessory muscles of respiration, EMG studies show no indication of respiratory function of these muscles. Instead, there has been some speculation that these muscles may be involved in proprioception, or the perception of body and joint position. The transversus thoracis muscle is thought to have little, if any, expiratory or inspiratory function. Muscles of the upper extremity that attach to the ribs and the sternum may be involved in the process of respiration by voluntary adjustments of body position. For instance, consider the sternocostal head of the pectoralis major, which originates on the ribs and the sternum and inserts on the humerus. If the humeri are elevated in a shrugged shoulders position, and the hands are braced against a stationary object, like the back of a chair, contraction of the pectoralis major muscles will elevate the sternum and the ribs towards the origin of the muscle on the humeri. This action will increase the volume of the thoracic cavity and increase the amount of air that can be inspired into the alveoli.
All right, it's time for a clinical correlation. Well, let's spend a little bit of time talking about emphysema, which falls under the category of a type of COPD, or chronic obstructive pulmonary disease. Emphysema can cause patients to have what's called a barrel-chested rib cage. Now, why is that? So in emphysema, the tiny air sacs, the alveoli, get destroyed over time. Now, there's less functional surface area for gas exchange. And due to the mechanical forces of ventilation that were just discussed, to compensate, patients have to use their accessory muscles of respiration. The overall volume of the rib cage enlarges. The area between the lungs and the bottom of the pleura is referred to as the Costodiaphragmatic recess. And during deep inspiration, or in diseases like inspiration, or like emphysema, the lung expands to fill that costodiaphragmatic recess. Now, the patient may have bigger volume within their thorax, but a larger amount of space that is considered dead space. Now, dead space is space or airway space where no gas exchange is taking place, so it's kind of worthless space, and that's why we call it dead space. The average person has about 150 mLs of dead space, which is the air in the trachea and the bronchioles, so you still need those things. And patients with emphysema, however, might have somewhere around 350 mLs or even more of dead space. So that's areas actually in the lung that's not participating in gas exchange. Now, if a large enough section of the lung is destroyed, sometimes we refer to this as a bulla, so a large area that's just kind of blown away and unusable, that area of the lung may actually be surgically resected. And this decreases the work of breathing for the patient and allows them to get better gas exchange overall with the remaining lung tissue. All right, so let's get going with a couple of these questions now. What is the name given to the space between the lungs and the bottom of the pleura? Remember, this is the costodiaphragmatic recess. Next question here, when does the lung occupy the costodiaphragmatic recess? So this is during exaggerated inspiration or in disease states that we just talked about, such as emphysema. All right, guys, now let's get back to Dr. Phelan and discuss the pericardium.
You may recall that the thoracic cage is filled by the left and right pleural sacs that house the lungs and the space between them, which is called the mediastinum. Anatomists have divided the mediastinum into superior, anterior, middle, and posterior compartments. In this solid anatomy lecture, we'll be focusing on the middle mediastinum, which contains the heart and the great vessels that connect to the heart. The boundaries of the middle mediastinum may be conveniently stated with a single word: pericardium. The pericardium is the sac that encloses the heart. It consists of a tough, inelastic outer fibrous pericardium and an inner membranous serous pericardium. The mediastinal pleura of the adjacent pleural sacs adheres to the fibrous pericardium, and the phrenic nerves run deep to the pleura, partially embedded in the fibrous pericardium. A brief review of the embryological development of the pericardium is valuable in understanding its structure. The embryo starts with a single coelomic cavity that is lined by a serous membrane. At about the 5th week of development, a transverse partition develops that separates the coelomic cavity into a thoracic and an abdominal cavity. Simultaneously, coronal pleuropericardial folds begin extending medially from the lateral walls of the thoracic part of the coelomic cavity, carrying the phrenic nerves with them from the body wall, and fuse in the midline to divide the thoracic cavity into pericardial and pleural cavities. The pleuropericardial folds thus consist of a middle layer of mesenchyme from the body wall, with a phrenic nerve embedded in it, between two layers of the serous membrane that lined the coelomic cavity. The inner serous membrane becomes the serous pericardium. The mesenchyme becomes the fibrous pericardium, and the outer serous membrane, which is the serous membrane of the pleural sacs, becomes the mediastinal pleura that adheres to the fibrous pericardium. Since the phrenic nerves are partially embedded in the fibrous pericardium, they are considered to be occupants of the middle mediastinum. These nerves are derived from the ventral rami of C3, C4, and C5, drop from the neck through the superior thoracic aperture to reach the mediastinum, and run inferiorly along the fibrous pericardium to reach the diaphragm muscle, which they innervate. They also carry pain fibers from the pericardium. The phrenic nerves are accompanied by the pericardiophrenic vessels, which are branches of the internal thoracic vessels. They supply the pericardium, the pleura, and the diaphragm. These vessels are also occupants of the middle mediastinum. The heart develops within the fibrous pericardial sac and pushes against the serous pericardial sac. The serous pericardium wraps around the heart, and when development is complete and the heart has filled the fibrous pericardium, there are two distinct layers of serous pericardium. There is a parietal layer of serous pericardium that lines the inner walls of the fibrous pericardium, and a visceral layer of serous pericardium that covers the heart. The visceral serous pericardium is also called the epicardium. The visceral and parietal serous pericardia are continuous with each other at the root of the heart, which is the area where vessels enter and exit the heart. The intrapericardial portion of these vessels are also covered by serous pericardia. The embryonic heart begins as a tube with a venous and an arterial end. During development, the heart folds and these ends are brought together. This results in the formation of the transverse pericardial sinus, a passage through the serous pericardial sac between the venous and arterial structures at the root of the heart. This sinus is found superior to the atria of the heart and passes anterior to the superior vena cava and posterior to the ascending aorta and pulmonary trunk. Another sinus, the oblique pericardial sinus, forms around the veins of the heart as they expand during development. It is found posterior to the left atrium of the heart and is bounded laterally by the pericardial reflections surrounding the pulmonary veins and the inferior vena cava. These two sinuses are important surgical and radiological landmarks. For instance, when a surgeon opens the pericardial sac anteriorly, she can pass a finger through the transverse pericardial sinus to isolate the pulmonary trunk and the aorta. If the surgeon is performing a procedure such as a coronary bypass, she could easily place the ends of the tubes of a coronary bypass machine into these vessels to stop or divert blood flow during the procedure. Between the serous pericardia is the pericardial cavity, which is occupied only by a thin layer of pericardial fluid that is exuded by the serous membrane. The pericardial fluid reduces friction when the beating heart, which is expanding and contracting, rubs against the inside of the pericardial sac.
All right, it's time for another clinical correlation. Now, I want to briefly bring up some pathologic conditions associated with the pericardium and the pericardial cavity. Now, in response to infection or other pathological situations, excess pericardial fluid may accumulate in the pericardial cavity. Now, clinically, this buildup of fluid is called a pericardial effusion. Now, it's also possible for blunt force trauma to the thorax to cause injury to the surface of the heart, and this may result in bleeding, and that bleeding can then go into the pericardial cavity as well. Now, the inelastic fibrous pericardium is not distensible, so the heart will become compressed by the pressure of pericardial fluid or blood building up in the pericardial cavity, and then the chambers of the heart will steadily lose their ability to fill with blood until the heart stops beating altogether. Now, this situation is referred to clinically as cardiac tamponade. Now, it is relieved by Pericardiocentesis, which involves placing a wide-bore hypodermic needle through the fifth intercostal space to the left of the sternum to penetrate the pericardium, and then using a syringe or catheter, you're actually withdrawing all this excess fluid. It's pretty gnarly looking. So also, the pericardium can become inflamed. Now, this is called pericarditis from infection, neoplasm, drugs, or even autoimmune or metabolic disorders. In pericarditis, you often hear what's called a friction rub on auscultation. You can actually hear the walls kind of rubbing together. The function of the pericardium is usually rather nebulously described as protection of the heart or prevention of overfilling of the heart chambers, but no long-term negative effects of surgical removal of the pericardium have been noted. All right, so let's answer a few of these questions here. First one here, what is a pericardial effusion? So this is abnormal accumulation of fluid in the pericardial cavity. What is a cardiac tamponade? So this is an abnormal accumulation of fluid in the pericardial cavity, putting pressure on the heart. So the difference between an effusion and tamponade is that in tamponade, you're actually putting pressure on the heart and causing some negative stuff. Next, what is pericarditis? That's inflammation of the pericardium. All right, guys, let's move on from the pericardium to the heart.
As mentioned during the discussion of the pericardial sinuses, the embryonic heart begins as a muscular tube with an arterial end and a venous end that begins beating and driving circulation at about the 3rd week of development. During the 4th week, the heart tube folds, bringing the arterial and venous ends towards each other, resulting in a 2-chambered heart. The chamber on the venous end is the atrium. The chamber on the arterial end is the ventricle, and the connection between them is the atrioventricular canal. In the weeks that follow, septation occurs, that is, septa form to divide the chambers and their inflow and outflow paths, ultimately resulting in a 4-chambered heart, with a separate vessel or set of vessels associated with each chamber. The right side of the adult heart, that is, the right atrium and right ventricle, receives deoxygenated blood from the body and pumps it to the lungs. The left side of the adult heart, that is, the left atrium and left ventricle, receives oxygenated blood from the lungs and pumps it to the body. The heart is said to have 3 layers. The outermost layer is just the epicardium, or visceral serous pericardium, that was described previously. The innermost layer, the endocardium, consists mostly of endothelial cells and is very similar to the lining of a blood vessel. The thick muscular middle layer is the myocardium, which is made of cardiac muscle. Cardiac muscle resembles skeletal muscle in that it is striated. That is, the arrangement of actin and myosin filaments within its myofibers, or muscle cells, results in alternating dark and light bands visible in the myofibers microscopically. Cardiac myofibers differ from skeletal myofibers in that they bifurcate, they are connected to each other by intercalated discs, and they contract rhythmically, spontaneously, and involuntarily. The heart is slightly larger than a clenched fist. The clenched fist of the person whose heart we're comparing it to, not your clenched fist, and is somewhat pyramidal in shape, with an apex pointing slightly anteriorly into the left, a base facing mostly posteriorly, and 4 surfaces. The apex is found at the level of the 5th intercostal space at the midclavicular line and is formed by the inferior part of the lateral edge of the left ventricle. The base is located at the level of the bodies of the 6th through 9th thoracic vertebrae and is formed mostly by the left atrium with some contribution from the right atrium. The majority of the anterior or sternocostal surface of the heart is the anterior wall of the right ventricle. The inferior or diaphragmatic surface is composed of the left and right ventricles. The right pulmonary surface, which abuts the mediastinal surface of the right lung, is mostly the right atrium. The left pulmonary surface, which is adjacent to the mediastinal surface of the left lung, is formed by the left ventricle. When viewing the heart from its anterior or posterior side, one can imagine it as a trapezoid, where its right border is the right atrium between the superior and inferior vena cava. The inferior border is the right and part of the left ventricle. The left border is the left ventricle. And the superior border includes the atria, the superior vena cava, the ascending aorta, and the pulmonary trunk. There are 2 grooves completely surrounding the heart that intersect with each other at its base. The atrioventricular groove, or coronary sulcus, runs between the atria and the ventricles and defines the plane of the base of the heart, which is the level of the 4 cardiac valves. The anterior and posterior interventricular grooves are continuous with each other at the diaphragmatic surface and run perpendicularly to the atrioventricular groove in the plane of the ventricular septum. Blood vessels supplying the heart run in these grooves, which are usually filled by fat.
Okay, let's stop here. Now we'll cover the remainder of the heart in another lecture. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go through those answers together. All right, let's get going. First question, what are the borders of the medial mediastinum? So this is going to be the pericardium. Next, what nerve or nerves innervate the diaphragm? That's the phrenic nerve. Next question, what ventral rami is the phrenic nerve derived? So that's a ventral rami of C3, C4, C5. Next question, what muscle assists in respiration by bringing the sternum closer to the skull and is innervated by cranial nerve 11? That's sternocleidomastoid. Next, what features make cardiac muscle fibers distinct from skeletal muscle? So cardiac muscle fibers, they bifurcate, they have centrally located nuclei, they're connected to each other by intercalated discs, and they contract rhythmically, spontaneously, and involuntarily. Next question. What sulcus defines the plane of the base of the heart? That's the atrioventricular groove. Next question. What thoracic level is the base of the heart located? That's going to be T6 through T9. Next question. At which intercostal space is the apex of the heart located? So that's the 5th intercostal space. This is more important than you would think. At the apex, there is what is called the point of maximum impulse, which in the normal adult can be felt in the 5th intercostal space in the mid-clavicular line. If this point is displaced, it can mean that the heart is enlarged, or that if it's on the other side, that patient might have dextrocardia, where the heart is on the other side, or dextrocardia situs inversus, where the visceral organs, all of the organs in the heart are actually located on the other side as well. Next question. What procedure is performed to treat cardiovascular compromise from blood building up in the pericardial cavity? Remember, from the clinical correlation, this is cardiac tamponade, and it can be relieved with a pericardiocentesis. All right, guys, we've provided some image for you to label again. Recalling these images in a timed setting will help you perform well on the practical part of your examination. So label the images, and then we'll be finished. Thanks.